Uh, we have our most sort of the teacher, Dr. Ajay here with us today. Thank you, sir, so much for giving us your valuable time. Students do look forward for your classes every time. So, sir, the stage is all yours.
Thank you for the kind introduction, Puneet. So the talk is going to be on transplant immunology. I hope Puneet had shared with you there are cases that we had built for
Yes, sir.
for a forum. And so I will try and build on those cases and use some of those cases for discussion. We'll share if we need to, we'll share those connect website link again after the talk as well. So in case someone wants to go back to the specifics of individual cases, or take their time with the single antigen bead reports and look at them on their own, they can do that as well. And then the answers are already in the website itself. So you can look at those as well. So my goal today is going to be kind of to build on those and kind of gives an overview of it as well. So when we look at transplant immunology and the immunological risk assessment, which we do for our patient or the recipient donor pair, the key is to understand what is it that we are trying to get an answer to, or what question are we trying to answer. And so when we do the cross match, the single antigen bead and the HLA typing, what we are trying to predict is antibody rejection. Predominantly hyperacute rejection, but also acute antibody rejection. What we are not trying to do, or what this evaluation will not do, is tell you anything about cellular rejection. There are certain risk factors, so like a higher HLA mismatch may increase cellular rejection, but this workup is not to identify cellular rejection. This is only to assess and try and predict or avoid antibody rejection, both hyperacute and acute antibody rejections. And so that's what we are trying to do. So if we look at the scope of the immunological risk assessment, and so this is from the Terasaki paper from 1969, and in this what he did was he did CDC cross matches for 681 prospective recipients. And what he found was that 19% of them had a random CDC that was positive. So it wasn't against the donor that he was doing it. He was just doing prospective recipients against a whole host of potential donors or potential blood donors, just to get a sense of what their sensitization was. And so at that point in 1969, 19% of them were sensitized. And when we do it now, even in this day and age, that ratio is not any different. About 15% of our potential transplant recipients are sensitized, whether you do it on a flow PRA or any other kind of antibody assessment tool based on HLA antibodies. And so the risk of so these are the patients who are sensitized in whom we are trying to evaluate the donor recipient pair. For the ones who are negative, who don't have any antibodies at all, you can not do any testing and take them forward for transplant as well, and you wouldn't be any wiser than you are with all the tests that you've done. So now let's look at when he looked at, this is Dr. Terasaki's paper, at the 248 transplants that had been performed in 63 recipients with antibodies and 163 without preformed antibodies. So those who had a positive cross match against the donor, 80%, so 30 were done, out of them 80% had immediate failures. And those who had a negative cross match, only 14.8% had it. And again, we are talking 1969, when the amount of immunosuppression, thymoglobulin, other immunosuppression, tacrolimus, those were not available. So some of these failures were likely low immunosuppression related or technical in terms of surgical technique as well, which in 1969 compared to now, with the number of surgeries that have happened, is probably better. And those who had no antibodies, so this was 14% was negative cross match, but they were sensitized. And if you had no antibodies at all, you were completely unsensitized, it was 2.4%. So no sensitization. So if someone is completely not sensitized, no blood transfusions, no transplant and no pregnancies, we have a very low risk of early AMR. However, what this doesn't tell you is late AMRs or chronic antibody mediated rejection. So if you have someone who has antibodies that are there, crossmatch is negative, but you could develop late AMR. And then it doesn't tell you if you under immunosuppress someone, if they develop DNO over DSAs, what's the risk of making antibodies and then rejection. So those are two things that this test doesn't tell you. But what it does tell you is if you have a positive cross-match, you're at very high risk of hyperacute and acute rejections and losing the graft immediately. If you have no sensitization at all, then you have a very low risk of any kind of antibody rejection early on. So I'll kind of summarize the talk up front and then we'll go into the specifics as well. So let's take different tests, the CDC and the flow cross-match, the single antigen bead, combining the single antigen bead with the donor HLA typing to tell you whether these antibodies are HLA donor specific or not. And then what should be our plan and what's the antibody mediated risk of rejection for a particular. So let's say there is no history of sensitization. The flow cross match is negative, single antigen bead is negative. If the single antigen bead is negative, then with the HLA typing, you know that it's not going to be positive because there are no HLA antibodies. You can move forward with the transplant and the risk of antibody rejection is low. So now let's take someone who has a CDC flow, which is positive, but the single antigen bead is negative. So the flow is likely false positive. We'll go over a specific case of this as well. In this situation, because you know that the single antigen bead is negative, there are no anti-HLA antibodies and there is no sensitization. So combining that, you know that this is a false positive CDC crossmatch. You can repeat it, you can cross-check it. And once you're sure, you can move forward and do the transplant with a low risk. If there is sensitization, but the CDC crossmatch is negative, the single antigen bead is negative, and the single antigen bead against the donor is also negative, overall risk is low. However, if the sensitization is there, CDC and flow are negative, but the single antigen bead is positive, even if it is not against the donor, and so there is no donor specific antibody, you have now moved from the low risk to low and medium because this person has had sensitization, has anti-HLA antibodies. So they may have epitope spreading and can then make antibodies later on after transplant. If you have sensitization, CDC flow as well as CDC flow is negative, but the single antigen bead is positive and they are against donor specific antibodies. These are against the donor and so they are donor specific. Then you need to discuss this with the donor and the recipient because you're now in the medium to high risk of antibody within the first 3 months. If you have a CDC positive or a flow positive with single antigen bead and these are donor specific, now you're at very high risk of antibody rejection within the first 3 months. And so you'll need to discuss and look for alternatives. And if you have a high risk sensitization, so this would be a child giving to a mother or a husband giving to a wife, in which you know that the sensitization is due to that specific person. In these, the sensitization itself is very high risk. So in this situation, even if the CDC flow is negative, the single antigen bead being positive and them being against the donor itself with memory as well, this is going to be a high risk transplant and high risk for antibodies. Okay. One of the keys that I think is very underutilized or underappreciated is that taking a good sensitization history is key. So previous transplant, previous pregnancies, numbers, previous transfusions, and donor relationship, have they seen these antigens before? As we were talking about, child to mother, husband to wife. So this is key and very important before you proceed with which kind of testing and what testing you have and kind of the overall risk assessment. So now we'll go through some of these cases and I'll try and keep some time for questions at the end. So we have a 45-year-old male on dialysis, wife is donor, he is Hep C positive. I'll skip to the key point and I'll see if I can get a pointer as well. So the CDC crossmatch is positive, but your single antigen beads are negative. So if the single antigen bead is negative, when we look at a CDC crossmatch, you take recipient sera, you put donor lymphocytes, you mix it with complement. If there are no donor specific antibodies, nothing sticks. Cells don't lyse when you put the complement and the dyes, and you can see healthy normal cells. If there are antibodies that are against the cell, they'll bind to it. You'll put the complement, the antibody binds the complement, and you have lyse cells, and you'll see the lyse cells. So this actually tells you that there is a complement binding anti-donor antibody. What it doesn't tell you is whether it is IgG or IgM. For IgM, you can DTT treat your CDC crossmatch, and if it turns negative, then you know it's an IgM antibody. And for whatever reason, IgM antibodies we can ignore. False positive would be if there are autoantibodies. And so you should look at a CDC crossmatch when it's positive, also at an auto. And if autoantibodies are there, usually have HIV, Hep C, lupus, those are possible reasons for autoantibodies. It can also be a non-HLA antibody that is there. In these situations, you can move forward with a transplant without any high risk. To be sure that these are false positive, you would want to do a single antigen bead, make sure there are no anti-HLA antibodies. So that would be the key to moving forward. So interpretation for a CDC crossmatch, if your T cell is negative, B cell is negative, you have three possibilities. One, there are no donor specific antibodies. Second, there are antibodies, but they're not complement binding. And so this would be a false positive, or the antibody titer is too low. For usually CDC crossmatch turning positive, you need antibody titers either individual or combined of about 10,000. If your T cell and B cell both are positive, then you're looking at either a donor specific antibody to class 1 or antibodies to class 1 and class 2. And so that would turn both the T cell and B cell positive. If your T cell is negative and a B cell is positive, then it can be a donor specific antibody to class 2, or sometimes even a low level to class 1, because there are more antigens expressed on B cells. It might turn B cell positive without turning the T cell positive for low level antibodies because the antigen expression on B cells is higher. However, if your T cell is positive but the B cell is negative, that should not happen because class 1 antigens are present on both. If your T cell is positive, your B cell should also be positive. So you should be looking for a technical error, could be due to B cell viability or could be due to some other aspect. And so those are tests where you would want to discuss with your lab and kind of go through it again. So what does a positive crossmatch predict? Again, going through the Terasaki paper, it predicts hyperacute rejection with good sensitivity, 80%, and specificity, 96% based on his paper. However, even at that time, 3 out of the 30 who had a positive crossmatch survive for more than 3 months. So just because you have a crossmatch positivity and someone reports a paper or someone reports, hey, I had a positive crossmatch, I desensitized them or I didn't desensitize them, I did the transplant and one of them survived and did well, doesn't mean that that's something new. That was reported even long ago in 1969. But that doesn't mean that we should be doing this routinely because you know that 80% of them are going to fail. So what is your plan for this transplant pair? So with the hepatitis C, we know that this is a false positive CDC crossmatch with no history of sensitization, negative single antigen bead. We can move forward and do the transplant. Second case is someone with polycystic kidney disease, wants a preemptive transplant with wife as donor. Again, the T cell crossmatches are negative for CDC and flow. However, the B cell flow is positive. Again, no sensitization history, no blood transfusion, and single antigen bead is negative. So again, when we look at a flow crossmatch, you have cells that you're taking, you're combining it with the sera of the recipient, then you wash it off. After you wash it off, if there are antibodies that have stuck, you go in with a fluorescent tag anti-IgG, and that will then fluoresce if the antibody is there. and you will get a mean shift. What it does tell you is that this is an IgG donor specific antibody. So because this is an anti-IgG that is there, what it doesn't tell you is whether it is HLA antibody or whether it is any other kind of donor antibody. So again, what it won't tell you is whether it is anti-HLA or whether it is complement binding. So for complement binding, you would need the CDC. Again, in terms of interpretation, very similar to the CDC crossmatch. If both are negative, either no antibody or the titer is too low. If both are positive, usually either to class 1 or 1+2. If B cell is positive, T cell is negative, either only to class 2 or a low level class 1, or sometimes can be a false positive as well. B cell and B cell viability as well as its interactions can sometimes lead to false positivity. If your T cell is positive for a flow, but B cell is negative, you should look for technical errors. So again, the false positive are the same as or similar to the CDC crossmatch autoantibodies with HIV, Hep C, lupus. Non-HLA antibodies can also cause it to be false positive. To diagnose it, you should always have an auto crossmatch as well. And if you have a negative single antigen bead, then you know that this is likely a false positive. In terms of cross matches predicting outcomes, so if you have a negative flow and CDC cross match, you shouldn't be having antibody rejections. If you have antibody rejections, if both the cross matches are negative and you have a good lab, you need to check what's going on. There's something not right happening. If your flow cross match is positive, but the mean channel shift is less than 300, you have antibody rejection rate, and predominantly you'll notice majority of the rejections are within the first 90 days. And so that is where your rejections are going to happen. After that, it's pretty much a flat line for most of them. And so you will have a low flow cross-match positive. You will have 20% antibody rejections within the first 45 days. Your flow cross-match is strongly positive, 30 to 40% within 45 days. And if you have a CDC cross-match, which is positive, 40 to 50% risk of antibody rejection within 45 days. And so that is something that these cross matches do tell you in terms of information. As long as we know that the anti-HLA antibody is the cause, donor-specific antibodies are the cause of this cross-match being positive. So for this patient with the negative single antigen bead and the no sensitization, we are pretty reassured that this is a false positive. We move forward and we can do the transplant. Coming to the third case, so this is Ankita, who's been on dialysis for a month and husband as a donor. So as soon as you notice this, your alarm bell should be going off. She has 2 pregnancies and husband as the donor. You do the cross match, everything is positive. T cell cross match, both CDC and flow are positive. B cell, both CDC and flow are positive. You do single antigen bead, multiple anti-HLA antibodies are present. So now, why are the CDC and flow positive? Due to these donor-specific HLA antibodies. So how do we identify them and what do we do about them? So in this case, first we'll talk about what we can do, and then we'll go into how do we evaluate and ensure that these anti-HLA antibodies are actually donor-specific. So options for this is desensitization. We'll talk about why not a good option for this patient. Alternate donor, they should look for maybe a brother or a sister or a sibling, a swap, or a deceased donor. So those are things that we can be talking about. Which one would be your first choice? So if there's only a little bit of antibodies, an alternate donor or a swap would be feasible. If there is, so let's look at this in terms of sensitization. So if it's only some antibodies, you could consider taking this person for a swap or another donor. However, if this is the antibody level here, finding an alternate donor for them, either on a deceased donor or a swap, is going to be extremely, extremely difficult for the amount of antibodies and the spectrum that they're already covering. So in these situations, a 2 haplomatch sibling or a 1 haplomatch parent or a sibling might be the best option. If it's a father, then a child might be. If it's a mother, then you know that these are antibodies that are likely to be against the child themselves. So those would be kind of options to consider. Would you compare and consider an ABO incompatible sibling versus an HLA incompatible? And that's something that you should think about. In ABO incompatible, the antibody mediated risk is about 10%. In ABO compatible, HLA compatible, it's about 2%. But as we talked about, if you have a HLA incompatible, your antibody rejection goes to 40%, 30%. So an ABO incompatible but HLA compatible is still likely to be better than an HLA incompatible that we're trying to desensitize, because in those, the antibody rejection rates are probably going to be 30, 40%. So something to consider, especially for patients who have very high sensitization in the 80, 90%, that they should be looking for siblings who are 2 haplo-matched. And even if they're ABO incompatible, they're better off with that transplant than a HLA incompatible transplant. Again, the same data in terms of 40 to 50% antibody rejections. So take-home messages from the cross-match part of it is, if your CDC cross-match and flow cross-match are useful tools, they are false positive and false negatives that are possible. So we need to be aware about them. For those who are sensitized with positive cross-matches, with anti-HLA antibodies against their donor, we need to look at these alternative options. So when we look at a single antigen bead, how do we assess it? How do we say it's donor specific? So that's kind of what we'll go into now. So when we talk about a single antigen bead, there are multiple beads that are there made by the company. Each single antigen bead has a single antigenic allele. So for example, an A0101. Another one is A0201. Another one is A0202. So now these beads panel, so for one for class 1, one for class 2, are going to get incubated with the serum of the recipient. And if there are antibodies that are against the specific donor antigen, which is on the bead, or any other antigen as well, those antibodies will stick if there are against these special HLA antigens. Then you'll wash it. Only the one that is sticking will remain. Then you go in with an anti-IgG with the fluorescent tag. You wash it again. All the others will wash away. And then you put it in a flow cytometer. So in the flow cytometer, there are 2 lasers. One to identify the bead. So this laser will identify which bead it is. And then the reader will know that this is an A0202. And then this second laser is looking for the fluorescence. And this, because there is no fluorescence, it's a very nice tight band, and it's going to be a low level of, let's say, 100. This 100 MFI that you get is an average of 100 A0202 beads. And so that average is going to be what is why you have this curve. Otherwise, it would be just a single line if it was one bead. So this curve is because you're averaging and making a bell-shaped curve for all the 100 beads. Then the next one goes in, and because now this is fluorescent, so you have this bell-shaped curve, which is significantly shifted here, and the mean fluorescent intensity is 4,000. So maybe for this bead, it's 3,000, but the mean one across 100 beads may be 4,000. And so then you get this report. So it will have the different alleles and the MFI values for all those alleles. So now when we look at this report, we say this person has anti-HLA antibodies. We don't say that this is donor specific till we have looked at the HLA typing report of the donor. So now we're going to look at the donor typing. And so let's look at this typing. The recipient is 0301 and 2301. The donor is 0202 and 1101. So we look at the 301 and the 2301, which are self-antigen. And so those have to be negative. You can never make anti-HLA antibodies against yourself. If you find a single antigen bead in which there are antibodies to self, there is a high background or some technical error that has happened. The high background can be from IVIG, from thymoglobulin, can be from those kind of things that have been given to the patient, or it can be from other hypergammaglobulinemia or some other issues that are driving it. So if you see a single antigen bead in which there are self antibodies, make sure you talk to the lab what's going on. Then you look at the donor typing, and you see that the 0202 is negative, while the 1101 is positive. And so you have a donor specific antibody against 1101. So the conclusion would be that there is a A1101, which is donor specific, while the other antibodies, the A01 is a anti-HLA antibody, but not donor specific. So coming back to Ankita, so now we know that she has these antibodies, including these A antibodies against her husband. Looking at the others, so let's say looking at B, so we look at the B antigens now. And again, there is a 801, which is positive, and the 5201, which is negative, which is not on this sheet. The 5701 is positive. However, there may be other beads, other HLA antigens that are not available. For example, there could be someone who has a donor with a 2407 or a 2403, in which we don't have that bead that is available. So 2407 is the donor typing. That bead is not available at all in the bead panel. So you can do a few things to try and answer the question, are there any donor specific antibodies or not? So you can use the antigen, which is 24, instead of the allele, the full allele, 2407, and you can look at other beads that are A24 and see if there are any antibodies. So 2403 is negative, 2402 are negative. So you can presume that 2407 is also likely to be positive. Similarly, let's say you have a donor who has a 0 to 11. So if we look at 02s for this single antigen bead, all the A02s are positive. 1, 3, 5. So you can assume that the 11 is likely positive. So this is one way of getting to that answer. Another way is to look at call the HLA lab, and they can look at the epitopes and the antibody profile, and then tell you whether 2407 or 0 to 11 is likely to be positive or not. So again, confirming the validity of the single antigen bead report with self antigen is pretty important and can be a good source of internal validity. So just like we did, A1101 and 2402 are negative. B 3503 and 5101 are negative. So again, you know that this single antigen bead is valid. So are HLA-C antibodies important, or can we ignore them? So again, if there are anti-HLA antibodies against C, these are important, have been shown to cause rejection by themselves without any A or B antibody as well. So you would need HLA-C typing to be able to answer the question whether those C antibodies that you see on a single antigen bead are against donors or not. Similarly for class 2, so you would need to go through step by step, looking at the donor typing, so DRB 0301 as well as 1001, to see if there are any donor specific antibodies that are there. In this case, the DQB 0201, which is here, has positivity of 4000. When we do class 2 beads, what you actually get is a DQ alpha and a DQ beta combination, because these alpha and beta are combined together. And so sometimes confirming whether these are donor specific or not can be complicated. So we'll show an example later on. So another key part of looking at class 2 is to be aware that there are DR 51, 52, 53, or also called DRB 345. These are drop-ins that happen with specific HLA DR combinations, but can happen separately also. So for example, DRB3 or DR52 is usually seen with 11, 12, 13, 14, 17, and 18. Or DRB4 is seen with DR4, DR7, DR9. But they may be present sometimes separately as well. So if you have someone who has single antigen bead positive for DRB3, 4, 5 on your single antigen bead, you will need to know whether the donor has that antibody, has those antigens or not. And so talking to your HLA lab is going to be important in this situation. Another question that is there, and kind of a curiosity question, is the wife only saw her husband's antigens. But despite seeing only her husband's antigens, she is now antibodies to hundreds and thousands of people. And so how did that happen? So one of the keys to understand, and so this is class 1, so you have an alpha 1, alpha 2, alpha 3, and you have the beta 2 microglobulin here. The antibodies that are anti-HLA antibodies may recognize any part of this. So they may recognize this part, they may recognize the hinge region, they may recognize the alpha 2 chain or the alpha 3. When we say HLA A0201, the difference between 0201 and 0202 or the 02 and 01 may be a very small part over here. And so if the antibody recognizes this may be present in 20, 30 different HLAs. And so even if you make antibody against one, you would then be making antibodies against 20, 30 different HLA antigens or HLA alleles. So because those epitopes may be common in many HLA molecules. If you look at class 2, you have the DQ alpha part and you have the DQ beta part. And so the antibody may be against only the DQ beta or only against the DQ alpha or maybe against DQ alpha beta combination. And so this is sometimes very important to identify because otherwise you might be refusing or not planning to move forward with the transplant, which was something that was actually doable, and then rejecting donors for a potential recipient. So how can we evaluate and assess someone who has multiple donors or multiple positive cross matches and kind of move forward for them? So let's say you have someone who has 2 pregnancies, you have the husband's typing, there is the elder son or the younger son or both of them that you have. So whenever I look at a family and a family pair, I start by making haplotypes. So haplotypes means because all your HLA A, B, C, DR, DQ, DP are on chromosome 6. They are all carried together. And so you will inherit all of them from your mother or your father in one group. And so what you can do is look at the son and say, what did he inherit from his mother? So the elder son, this is what he inherited from his mother. And because the mother is the recipient, you don't have to worry about antibodies against her because those are self-antigens for the mother. What did he inherit from his father? So this is what he's inherited from his father. For the father, the same one that is in the son, and then there's going to be the second haplotype. And so you have these. Now, when you look at the antibodies, what you realize is that all the antibodies that are there in the mother are only against the second haplotype. There is none of it against the first haplotype, which is what this elder son has. And what it means is that what happened for this mother is that the first pregnancy did not sensitize her. The second pregnancy did. And in the second pregnancy, the younger son got this haplotype and not the other haplotype. And so actually the elder son is a very good transplant donor for her and would be someone who she doesn't have any antibodies against. And so those are things that you will be able to evaluate and be able to offer to patients and recipients once you do it in a systematic manner. Okay, coming back to the DQ antibodies as well, we look at some of them here. So I don't know how much you can see, but these are available on the website as well. So all of these 3 antibodies have a DQ alpha, which is 0201. The DQ betas are different, 0601, 0302, and 0401. And there are other beads here at the bottom of the pile, which are the same DQ betas, which are negative. So what it means is that the antibody is actually recognizing DQ alpha because all the DQ alpha 0201s are positive. And the same DQ beta 0601s or 0302 or 0401 are negative here. So like this is 0401. So what you know is that this is an anti-DQ alpha antibody. And so what you will need is to know the DQ alpha typing of your donor as well, which again is not something that is routinely done unless you ask your lab or you're sure that they're going to do that as well. So if you have someone who's very sensitized and you have DQ alpha antibodies as well, you would need DQ alpha typing as well. So now we'll move to the next case. 20-year-old boy, Amit, going for his third transplant. First transplant in 2011, second transplant with his father. Second transplant was an unrelated. Underwent a nephrectomy of the second transplant due to graft intolerance in 2022. And he has single antigen beads multiple times, once in 2019 and once before the nephrectomy in 2022. And he has multiple potential donors. So you have the typing of the first donor, you have the second donor, you have the father, sister, you have a maternal cousin, you have emotionally related donor, and then you have the recipient typing as well. The cross matches haven't been done. You have single antigen bead, reports from 2019 and 2022. And then the question that the family is going to ask you is, what can we do? Who can we move forward with? How do I do? Because I've had multiple cross matches which are positive with other donors. And this is a sensitized patient because they've had 2 transplants and then they have 10 blood transfusions as well. So the first question is, should we consider the single antigen bead from 19 at all? And the answer is yes, because it will have memory. So if there is significant difference between 2019 and 2022, even if there are antibodies that were there in 2019 and are not there in 22, but if they're donor specific, they're going to be important because there'll be memory behind it. And the 2022 is important, but after that, there's been a sensitizing event. You've done a graft nephrectomy and you've stopped immunosuppression. In this setting, there can be higher sensitization as well. And so you would need to reassess this sensitization as well. So again, step 1 is to make haplotypes. So you can, the recipient from the mother, recipient from the father haplotype that is not been shared with his son. And that's what the antibodies were against. So you have an 18,000 against B49, 9 and 10,000 against DQ2. The father's sister has a haplomatch which is inherited from and common to not common to the son. And then there are other people who are not related, and their HLA typing also shows antibodies, but only against this 58. So the issue is that there are antibodies, and these are high-level antibodies. So moving forward is not going to be easy. And you know that some of those have memory as well. The other part is that the second transplant donor, this 30 that is there, is also available here. And so if we repeat the single antigen bead, there is a high possibility that now he's making antibodies against this 30, which will pop up once we redo the antibodies post the nephrectomy and stopping immunosuppression. Which is why if someone is planning to move forward with a second transplant or a third transplant, keeping immunosuppression going for them is critical to ensure that they don't get heavily sensitized and then can't get a second transplant or a third transplant. So if you're planning a desensitization or taking forward with someone who has HLA antibodies, what should you discuss with the family? So again, this is something from Dr. Seghi's paper in 2014, where he looked at multiple centers who were doing CDC crossmatch positive transplants and desensitizing them. And so this is graft loss, and we'll get to antibody rejection, which we looked at before as well. And so what you see is that you have graft loss of about 8 to 10% for CDC crossmatch right up front. And at 5 years, 40% graft loss is there. And this is despite desensitization and then multiple treatments for antibody rejection, which will include eculizumab, splenectomies, and the like. And so this is something which, in my mind, in India is not feasible at all. Nor probably is this, which is a flow crossmatch positive with single antigen beads and HLA donor specific antibodies, where you have 30% graft loss at 5 years. If you do only single antigen bead positive with crossmatch being negative, you're at 20%, and your routine HLA compatible transplant is at 17% graft loss over 5 years. When you look at the strength of the antibody, they do predict crossmatch. So antibodies about 20-25,000 will turn your CDC positive, flow crossmatch around 10 to 15,000. For a high flow crossmatch, about 5 to 10,000 for a low flow crossmatch, and negative are going to be much lower. And as we discussed before, your cross-match will predict antibody rejection. We've reviewed that before. If you look at just single antigen bead, if your single antigen bead is negative, risk of antibody rejection is very low. If you're between 5,000, less than 5,000, or 5,000 to 10,000, and these are donor specific, you're in the 20% range. If your donor specific antibody is above 10,000, you're at 40 to 50% antibody rejection risk at, again, 45 days. So before desensitizing or deciding that you as a program want to desensitize, I think what is important is to get a comfort level of what immunological risk you and your program is willing to accept. You have to discuss with the patient and the family other options, looking at alternative donors, especially in highly sensitized, looking at siblings, because you have a 25% chance of having a 2 haplo matched, even if they are ABO incompatible. A swap, especially if the sensitization level is not high or not too many antibodies are there. Sometimes not doing a transplant and continuing on dialysis might be the best option for a particular patient also. And then lastly, if they're ready, doing an HLA incompatible transplant, understanding the risk of AMR, and if there is an AMR that they'll need biopsy, single antigen bead, IVIG, plasmapheresis, rituximab, ATG, and this is going to cost almost the same or even more than the original transplant. And that if they do have an antibody rejection, their graft survival is going to be lower. So these are things that I would want to discuss with the transplant donor pair. And if they are okay and they have no significant financial issues, because all of this is going to be very financially taxing if they do have a rejection. My thought process and protocol is if the CDC is positive and this is due to donor specific antibodies, do not desensitize. If the flow is positive and the mean channel shift is more than 300, which is a strong positive, and this is due to anti-HLA antibodies against the donor, do not desensitize. If there is a single donor specific antibodies, again, more than 10,000, don't desensitize. And if there are multiple donor specific antibodies above 5,000, my preference would be not to move forward. How do you desensitize? This is something that most of you already know. Plasmapheresis, IVIG, rituximab, PAC, MMF, PRED, giving extra ATG. All of those would be critical depending on how high the antibody is and what your plan is. Making sure that you don't do a cross match after you've given Ritux is critical, because then your B cell flow is almost 100% going to be positive. During the transplant, give more ATG, up to 4.5 mg per kg is what I usually give compared to my usual 3 mg per kg, but you may even need to consider higher doses. And then post-transplant, very critical to make sure that you don't lower immunosuppression too much, neither early nor even 1 or 2 years or 5 years later, because this is someone who has preformed donor-specific antibodies and having a short threshold for single antigen bead and biopsy. So last case, and then I'll open it up for questions. So you have someone who is a 40-year-old female, 2 pregnancies, had severe postpartum hemorrhage in her second pregnancy, remains on dialysis, has cortical necrosis, and has transplant options from multiple donors have been reviewed at 3-4 different centers, and all of them have crossmatch which are positive. She has a single antigen bead done, which is a PRA of 95 to 98%. With multiple antibodies across everything. So what can we offer her? In my mind, the best thing we can offer her is a sibling. And so you would want them to do HLA typing of their sibling before doing any other workup, and without blood group compatibility being a factor. And what I would offer is to do all their siblings and consider a 2 haplo match HLA compatible, even if ABO incompatible. And would you consider desensitization? As I discussed, look at the program level and your heartache, and based on that, you can take a final call. So 40-year-old female Kudrat has here for a first transplant, multiple possible donors, but has multiple antibodies. And so she is looking for which one to proceed with. So again, she has her father, mother, sister as potential donors. So again, if you have these, make haplotypes, because then you can reassess them. So this is the recipient, what she got from her mother. This is the recipient, what she got from her father. This is the mother that she has not given to her donor, dinner to the recipient. And you can see that there is this one antibody, 2200. What she has not inherited from her father in the father, and there are 3 antibodies. When you look at the sister, for the sister, she has gotten the same as this, which is in the recipient, which is inherited with the father, but the not inherited from the mother. So this sister is going to be exactly like her mother. So now, from an immunological standpoint, the mother and the sister are the same. All you need to do is to evaluate medically, and then you can discuss with them that this 2000 antibody is probably her best case scenario with all the antibodies that she has, and the sister or the mother might be someone who you could desensitize and move forward. So concluding, back to the original slide, no sensitization, every workup is negative, move forward. Only CDC is positive, but single antigen bead are negative. This is a false positive, move forward. Sensitization is there, but everything is negative. You can easily move forward. Sensitization is there, single antigen is positive, even if it is not donor specific. You are in low to medium range. Probably the best thing is to move forward, but with some thymoglobulin and some monitoring and planning around it. Sensitization, which is donor specific antibodies, medium to high risk, you need to probably look for alternatives and discuss with family. Cross matches, which are positive due to donor specific antibodies, very high risk. High risk sensitization, naturally with positive cross matches, or even if no positive cross match, but just donor specific antibodies, you're at high risk. So my take home is if you want to defy HLA antibodies, try and go under the hurdle rather than trying to climb over it and avoid them. And so I would now want to take questions, and please feel free to put it in the comment section also, and we'll try and see if I can take questions from the chat as well. So question, number of blood transfusion for high risk sensitization. So again, the most sensitizing event is a transplant. The next is pregnancy. And the next lower than that is blood transfusion. There is no particular number that you can do, which will tell you one transfusion may be enough for sensitizing against a particular person. And so in my mind, any blood transfusion is a sensitization. And in my thought process, if they have a blood transfusion, I would treat them as they are sensitized, and for all of them do cross matches, CDC and flow, and a single antigen bead as well. Can you explain PRA, how it is done and significance in our population? So there are 2 different PRA. The one PRA that was done originally by Terasaki and was popularized after that was you were doing 50 people CDC crossmatch for every potential recipient. And you would say how many of those were CDC crossmatch positive. Now you have multi-antigen beads. So I showed you single antigen bead where one bead has one antigen. You have multi-antigen beads, and those multi-antigen beads are made by the same companies. You run it on your flow cytometer, and you will get a PRA positive, negative. So that is one kind of PRA where it's just a qualitative yes, no. And there are then PRAs that are multi-antigen beads but are quantitative or semi-quantitative, where they'll give you a percentage, 10%, 15%, 20% also. In current day and age, if you want to just assess your donor, are they sensitized, are they not, you could do a PRA. But if you want to assess for a particular donor recipient pair, what's their risk, you would need to do a single antigen bead, especially if they are sensitized. So rituximab is an anti-CD20 antibody. B cell have CD20 antigens. The rituximab will be sticking to your B cell. So whenever you go in with your anti-IgG flow crossmatch testing, those antibodies will stick to the rituximab, which is sticking to the B cell, and it will turn your crossmatch positive. And so that is how your B cell flow crossmatch is very high likelihood to be positive after rituximab. And so the plan should be no cross match after rituximab. So what make your plan beforehand? If you're giving rituximab, let's say for an EBO incompatible, do your cross match first. give your rituximab, and after that, don't do a cross match and just take them for transplant. If you're doing an HLA incompatible one, you're doing desensitization, do your cross match first. And after that, you're not doing a cross match. All you want to do a single antigen bead and do it that way. So another question is, can you explain about the concept shared epitopes? So let me go back and share my, I'm not sure if my screen is still sharing. Can someone tell me if my screen is still sharing?
Yes, sir. The
Yes,
screen
it's
is
on.
visible. Yes, sir.
Okay. So let me kind of pull up this photo here. So what you have actually when an antibody recognizes something is it recognizes a combination of 3 or 4 proteins. And those 3 or 4 proteins are a combination of epitope or eplet. And these are words that are sometimes used synonymously or interchangeably. But the smallest group of proteins that the antibody recognizes is this eplet. And those eplets can be shared across many HLA. So let's say you have A02, it might have an eplet or an epitope of, let's say, 62 GWC. There is our naming conventions that they have. That 62 combination may be in A02, it may be in 0201, 03, 05, as well as in A5, A7, A10. And so now, if you have an antibody that recognizes this 62 GW combination, it will be an antibody that is now against 02s, 05s, 07s, 010s. However, there may be an A02, let's say 0211, which doesn't have this epitope. And so 0211 may be a compatible donor for a particular person. So which is why people are now moving towards using this information, and the lab is now getting this information as well. However, how well and how quickly they'll be able to start using it is still up in the air. And hopefully soon we will have these things that the HLA lab will then clarify for you. Another question is, leukodepleted PRBC, is it better than PRBC transfusion? So absolutely. The sensitization that happens with PRBC is due to HLA antigens that are expressed on WBCs and are then seen by the blood transfusion recipient. And so those are how you get it. If you leukodeplete it, you decrease the risk. If you irradiate the blood, it decreases the risk even further, because these WBCs are also lysed. The leukodepleted WBCs are also lysed. So irradiated blood would be even better than leukodepleted, and leukodepleted would be better than just a plain PRBC, which is better than a whole blood transfusion, which is the worst of the worst as well. Another question is, can you explain Craig and public epitope? So Craigs are, again, when we talk about epitopes and eplets and those can be across many groups. So like one of the most common things is CW6, CW4. So those are very big, BW6, BW4. So those are very big common epitopes. And if, let's say, the recipient has BW4 and BW4, and they got a transplant in which the recipient in the donor had a BW6, they may make antibodies against BW6. And so that will then rule out probably 30% of your potential donor pool, 30 or 40%. And so that can be a very big common epitope that someone may make antibodies against. So how can we know that our hospital lab is reliable? Very important and critical question. So I think if you have your lab inside your hospital that does CDC crossmatch, flow crossmatch, single antigen beads, and the like, the key is looking at the reports, discussing with the lab, and then looking at outcomes. So if at any point you are having antibody rejections early on day 7 or hyperacute rejections, then you know that something is wrong. And so those would be things to look at. We did discuss if your single antigen bead is showing anti-HLA antibodies that are against self, then you know something is wrong. So those are things. Or if your CDC crossmatch is turning positive, or flow crossmatch is repeatedly turning positive for people who have no HLA antibodies, again, something that will give you a click that maybe something is wrong in the technique or the technician or how they're handling those things. And so those are ways to kind of question what or how good or reliable the lab is. Next question is, in our institute for suspected ABMR, we first do screening PRA and then check for class specific DSA. If you already have a ABMR, doing a single antigen bead is probably the best test, because this is now not a pre-transplant evaluation. You have someone who you know or think you have an antibody rejection. So antibody rejections are usually day 1, day 5, day 7, that kind of time frame. You have someone whose creatinine's urine output had improved, urine output was good, creatinine was coming down, creatinine's now day 5, day 7 going up. Very high likelihood you have an antibody rejection. You could have cellular rejections also if your TAC level is low and you didn't give any thymoglobulin or any induction. Those are also situations in which you could have a cellular rejection. In this situation where your suspicion is high, the best test to do is to do a single antigen bead, because you are high probability that there is antibody rejection. Your pre-test probability is very high. A screening PRA would not lower your pre-test probability enough after this test is done. So I would recommend a single antigen bead in this situation. So next question is relative intensity score and distributive strength of DSA a factor being considered for desensitization? I'm not sure how many people would understand this relative intensity score or an MFI. I'm going to answer this slightly differently. So when we look at an MFI report, let me kind of open up one of these above and kind of show you. I'll use an A, which is easier to kind of go through. So I'll kind of show this one here, the one which is positive. So let's, yeah. So when we look at this report, so I hope people can see it. I'll kind of make it full screen as well. Oops. Yeah. So, yeah. So you can see that you have antibodies against A0205. Let me get my pointer again. A0205, which is labeled as 16,000, 0202, which is 14,000, 0203, which is 14,000, 0201, which is 14,000. So these are all probably against the same epitope. If instead of giving 4 beads of the same epitope, I had given them 1 bead, it is likely that the titer of this antibody level would be much higher. And so this strength of MFI is a surrogate, but it's not a great surrogate, and it is not to be used literally in some of these situations. And so you have to say, if you have someone who is A0202, the actual antibody level, if I only put in A0202, is likely probably 20, 30,000. And so that is something where the strength. So if you have multiple antibodies which are 2,000, it's possible that the actual level is 4, 5,000. But because this is the way the reports are done, this is the way the analysis and data is done. So we are currently using the current way. Hopefully with epitopes and epilepts, we might be better in the near future. So another question is, wouldn't the high resolution HLA typing reduce the donor pool? To what extent should we type the HLA ideally and practically? So right now, if you look at HLA typing, if you do typing low resolution by SS or SSP typing, you're going to get charged 15 to 19,000 for each. NGS typing right now is available cheaper. It will give you A, B, C, DR, DQ, DP at least from most. And now companies are coming in where they will provide DQ alpha as well as DRB 3, 4, 5. Should be out soon, or some companies may have already started. at the same rate, which is going to be in the 15,000 or cheaper. So in my mind, even if you don't need it now, let's say there is someone who's not sensitized at all, I would do HLA typing that is as comprehensive as possible, not just for now, but also for 1 year later, 5 years later, 10 years later. Anytime he has a rejection and I have a single antigen bead, I would need the full typing of the donor. What if the donor has died since then? I wouldn't have the typing and I would have no way of getting the typing. So in my mind at present, it's cost effective and it is better to do full NGS of everything. So cell-free DNA, a couple of questions for cell-free DNA. That's a whole talk in itself. So I'm not going to take the cell-free DNA at present. And I'll kind of leave that out for now. So another question is, do we have to routinely ask labs for serial dilutions to remove prozone phenomena, or they do it by default? So no one does anything by default. If you suspect prozone in a patient, this would be especially in patients in whom you have a very high sensitization history. So let's say someone who's had a transplant and 6-7 transfusions, and they give you a single antigen bead which is completely negative, meaning there is no anti-HLA antibody alone at all. That would be highly surprising to me. So in this situation, I would talk to the lab and say, can you check for prozone? Another situation would be someone in whom I have a flow crossmatch positive in a severely sensitized patient, someone who's had, let's say, 20-30 transfusions, and I have a flow crossmatch which is positive. So I have a prior possibility and probability that this is an anti-HLA antibody, and they give me an anti-HLA antibody report which is completely negative. In which case I would say, please, I am pretty sure this is actually real. The flow crossmatch is real. In this situation, I would want you to do prozone or dilutional and repeat in those situations for that. Any safe time interval for which we should avoid doing a retransplant? I'm not sure there is any specific time interval. If someone has had a failed transplant, you can do a preemptive second transplant also. There is no reason why we need to get them to dialysis and then do a second transplant, or we have to take them off immunosuppression, because if we take them off immunosuppression, then the risk for sensitization becomes higher. So in my mind, a preemptive transplant is good for a first time transplant. A preemptive second transplant is good for a second transplant. Being on dialysis is probably bad for everyone. So I would say a preemptive second transplant, and you don't need to wait for that. So sticky B cell phenomena, what is a sticky? It's just a name that we put in for a B cell flow which is false positive. So there is nothing special about it. There is nothing fancy about it. It's just a name, and it makes people understand each other when you're talking between HLA labs or between physicians, that there was a B cell flow which is positive, single antigen beads are negative, and there is no sensitization. So we are pretty confident that this is a B cell flow which is falsely positive, and then you can move forward. However, if there is a very strong history of sensitization and you have a B cell flow which is positive, I would go back to the lab, ask them for doing dilutions to make sure that this is not due to other phenomena, and this is not a real B cell flow which we are ignoring. So I think those were very good questions, and so means that people were attentive and listening. So I'm very happy. And I would encourage everyone for reviewing this again. They can go back to the website and the link which Puneet has shared. Similar question, cases, as well as single antigen beads and their analysis is there. So, and please feel free to reach out to me either directly through email or WhatsApp for any questions or concerns that you have. Thank you.
Thank you so much, sir. Any questions still left, or I think so we have answered many of them. So again, thanking you for giving us your time, sir.
Thank
Every
you.
time whenever
Thank
we
you,
ask
Puneet.
for. Right, sir. Thank you, sir.
Okay, bye.